can go ahead. Ladies and gentlemen, welcome to the A to Z Introduction to Implantology for the revision course for the West African College of Surgeons. My name is Christopher Gonsalu from the Caribbean. So, I'm going to begin by sharing with you these few slides relating to the sequence of placement of implants. Once you raise the flap to expose the bone, the next thing to do is to use a round bore at a speed of about 1,000 RPM to 1,200 RPM to perforate the cortical bone. And the next thing is you're going to use a pilot drill, which is graduated, usually 9 millimeter, 11 millimeter, 12 millimeter, and up like that. And you're going to drill into the perforated cortical bone, right into the corticocancellous bone to the length of the proposed implant. So by this, you are beginning to create what is called the osteotomy site. And the next thing is to use a countersink drill so that you prepare the cortical bone, the crestal part of the cortical bone, to receive your implant. And then you now use a wider drill, which is a larger drill, which will drill precisely to the size of the implant that you want to place. And the next thing is to now remove your implant, sterile implant, from the pack, and you place your implant. And there are different ways of placing the implant. You can drill it in, but I will not suggest that. I usually use a hand driver. It's more interesting, and you can protect the crestal bone from shattering, especially in the maxillary region. As you can see, this is now removing the mount from the implant that you have driven in, and then placement of the cover screw, and that is it. The foundation for placement of implant, I have shown you a situation where there is bone, and you can sink in bone implant into this lovely bone without any sort of bone grafting. But there are situations where you will have to prepare the alveolar bone to receive implant. So you need to understand the type of bone graft that will be needed. Allograft, these are bone that you are getting from another human being. And it has the benefit of avoiding a donor site from the person that you are preparing for implant. So there is no additional donor site mobility, and Dynagraft, Grafton, and demineralized freeze-dry bone are examples of allografts. The significant concern about this product is the perceived threat of transmission of HIV and hepatitis virus. And I say perceived because most companies that manufacture allograft have already tested the person before death for HIV and hepatitis virus. Autogenous bone graft, of course, is bone that you are harvesting from the same person that is receiving the implant. And this autogenous bone graft is the standard by which all other bone grafting materials are compared. And there are several sites within the human being that you can harvest autogenous bone graft. And this includes the maxillary tuberosity, mandibular ramus, mandibular symphysis, and these are the intraoral sites. You can also harvest from oral tori or other exostosis, You can also harvest from zygomatic buttress, and the extraoral sites are usually the iliac crest bone or the tibial plateau. And the next is the xenograft. The donor of the xenograft is a different species from the recipient. So the xenograft can come from cow, pig, can come from horse. You know, it's just not a human. And most xenografts used in dentistry for the purpose of bone grafting are derived from bovine source, and example is the bio-os, which many years ago, I used to be so crazy about it. Everything was bio-os, 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 and this was what I used for my PhD experiment. However, recent concern of the transmission of bovine spongiform encephalopathy, which is called the mad cow disease, is of concern with xenograft, especially when it is coming from cows. The disease transmission is by sublevel particles known as the prion in bovine tissue. There has not been any reported case actually happening. However, some clinicians are beginning to avoid bovine grafting material for the reason of mad cow disease. Synthetic bone should be mentioned, and they are actually called the artificial alloplast. The xenograft that I mentioned a while ago are called the natural alloplast. So xenografts are natural alloplast, and synthetic bone are artificial alloplast. So we're going to look at the synthetic graft, and example include the bioactive glass of calcium phosphate, like the BioGran or the Perioglass. And these material, as you will find out later, do not perform well on their own when the goal is implant replacement. However, when mixed with calcium phosphate or even other bone substitutes, they have been shown to enhance peri-implant bone regeneration, as you will find out. So it is my duty to introduce you, my distinguished students, postgraduate students, to the bone physiology and anatomy. And I will say to you that once the patient expectation have been determined, the critical element of importance is the quality and the amount of available bone in the proposed implant site. And we're talking of quality. The bone quality type and density is not limited to the specific anatomical region. For example, you might find a type 3 or type 4 bone in the posterior mandible. And normally, you will expect to find type 2 bone in the posterior mandible. So this table here shows the classification of bone quality and density, as you will realize. So the D1 bone, which I will tell you right away, is found in the anterior mandibular region, is dense compact bone. And the good thing about this bone is that when you sink implant in this region, you can load immediately. And when you are drilling, the tactile sensation is similar to drilling into an oak wood or maple wood. D2, which is the same thing as type 2 bone, is porous compact. In other words, it has a lot of compact bone and there is some limited amount of cancellous bone. And when you are drilling into it, it feels like drilling into spruce wood or white pine. And you find D2 bone in the posterior mandible. D3 bone, which is found in the anterior maxillary bone, is coarse trabecular, And the drilling tactile sensation is similar to drilling into the balsa wood. And the type 4 is the fine trabecular, which is found in the posterior maxilla. And while you're drilling into a D4 bone, it's like drilling into a styrofoam. And a very sexy lady with very nice long nail can use the nails to drill into the posterior maxilla if we're not careful. So you may find that I have used the classification of bone referred to as type 1 right to type 4, but you can also call it D1 right to D4. Okay? It doesn't really matter. Now, let us look at type 1. Type 1 is composed mainly of compact cortical bone, as I said. It has minimal trabecular space, making this the densest type of bone. The implication is that the initial bone to implant interface is approximately 80% with a threaded implant. And it takes approximately 3 to 4 months for osseointegration. And this is where you find it, anterior mandible. And the D2 bone generally displays good thickness of cortical bone in superior or inferior border with more trabecular quality bone in the center of the mandible, and progressive bone loading should be considered. The implication of this is that the initial bone to implant interface is approximately 70% with a threaded implant, and the healing time is about 4 to 5 months. And this is where you find it, in the posterior mandible. And the type 3 bone, which is found in the anterior maxilla, has considerably less crestal cortical bone than type 1 and type 2, and the remaining bone is quite trabecular, and progressive bone loading should be considered. Of course, there is an implication. The implication is that the initial bone to implant interface is 50% with threaded implant, and approximately the healing time is 4 to 6 months. And this is where you find it in the anterior maxilla. And then the type 4 bone is in the posterior maxilla, and I have told you that this is found in the posterior maxilla, especially the atrophic maxilla, and it is mostly trabecular bone, and the osseointegration is guided. The implication is that the initial bone to implant interface is approximately 25% with threaded bone, and the approximate healing time is 8 months. And the implication is that a patient may say to you, oh, when Mr. So-and-so did the implant, Mr. So-and-so got it restored after 3-4 months. But you are doing your implant in the posterior maxilla. And as far as I'm concerned, I may even want to wait for 1 year before I restore it for you. And additionally, for fixed restoration, you must avoid cantilever in the posterior maxilla because of this D4 bone. And you must consider a minimum of 1 implant for each tooth replaced. Okay? And that is where you find it. So I want to introduce you to the concept of available bone. Bone in the proposed implant site needs to be evaluated in 3 dimensions. That is to say, the height, the width, and the length. The 3 dimensions of available bone as they relate to the selection of implant is as follows. The height, this determines the maximum length of implant placed in that site. The width determines the maximum diameter of an implant placed in that site. And the length determines both the maximum diameter and the number of implants that you can place in that site. And I will show you as we go on. You can see the height, and you must measure the height from above or below the vital anatomical structure up to the crestal bone. And that is the width of the implant, and then that is the length of the bone. And what I'm going to do now is to show you this edentulous space, which is 14 millimeters. Now, how many implants can you place here? If you know that each implant must be 2 millimeters away from each other and must be 2 millimeters away from the adjacent teeth, then it makes sense that if you are placing implants which are approximately 4 millimeters in diameter, then you can only place two of those 4 millimeters in diameter, because you need a 2 millimeter space between the adjacent teeth and the first implant, and you need another 2 millimeter space between the two implants, and you need another 2 millimeter space between the next implant and the adjacent teeth. So, or tooth rather. So 2 plus 2 plus 2 is 4, and then 4 plus 4, 8. 8 plus 6 is 12. So 2 plus 2 plus 2 is 6. And then 4 plus 4, 8. So when you add 6 to 8, it is 14. And that is the length that you have there for the edentulous space that you want to restore. So we're going to look at stress distribution. God, in his own kindness and wisdom, say in the maxillary region, created us with 3 roots for the molar teeth. And it will be very unwise when you are doing immediate implants to place only 1 implant, because you have 3 sockets. It may be wise, and it is actually wise, to place in 2 implants, and this will give you a better support for the restoration. If you are going to use 1 implant, it means that you are going to destroy the interdental septa, and it means that you're going to use a wider diameter implant, like a 6 or 7 millimeter implant. This may not be wise. And as you begin in the near future to place implant, you will appreciate this. This is something that people should not even tell you not to do. You have to find out why you shouldn't do it on your own. Okay? So, I am going to now take you into the oral surgery complications of dental implants. And this oral surgery complication of dental implants, I think you need to know it very well before you go into any exam. I'm telling you this. Now, I have divided the complications into reversible or irreversible, or both. In other words, complications that are reversible or complications that are not reversible. And there are some complications, as you will find out, they are both reversible and they are irreversible. And you, as a good clinician, will use your discretion to either treat it as reversible or treat it as irreversible. What you mean is that if it is irreversible, it means that, well, you have to take out the implant, or the complication that you have created has led to something very permanent. And if you don't do certain things, there may be medical legal consequence, in addition to detrimental consequence to your patient. And you can also classify complications of implant placement, surgical complications, into immediate or delayed. And also there are site-specific complications. And I will say to you straight away that when you are placing implants in the mandibular bone, you cannot have perforation of the maxillary sinus because there is no maxillary sinus there. You get what I mean? And if you are placing implant in the maxillary bone, you cannot have lodgement of implant into the sinus because, yeah, you can have that, but you cannot have damage to the inferior alveolar nerve because that nerve is in the mandible. Okay, so you can also divide complication at surgery to complications that affect the soft tissue and those that affect the hard tissue. The complication can be related to instrumentation, and I will say to you that one of these complications relates to damaging of the cortical bone or fracture of the pilot drill in the bone, and so on and so forth. So let us look at the site-specific complication. In the maxilla, you can have perforation of the maxillary sinus, and this is reversible because you can use glue, you can use membrane to repair it. You could have dislodgement of implant into the maxillary sinus. This is also reversible because if that happens to me, I'm just going to put on my suction machine and I'm going to suction out the implant by enlarging the osteotomy site, and I will consider to do some complex bone grafting. So the perforation of the nasal cavity is also a complication. Damage to the root of adjacent site is also a complication. Surgical emphysema is reversible, it's a complication. An infection is also a complication and it is reversible. And in the mandible, you could have damage to the inferior dental nerve, you could have damage to the mental nerve, and you could have surgical emphysema. And complications that relates to instrumentation include surgical emphysema, fracture of the ball, and infection. So what is the sequelae, the consequence of these complications? Discomfort to the patient, infection, pain, numbness, lack of osseointegration, delayed osseointegration, and possible medico-legal action. And I will tell you at this point that the virtual dental school TV on YouTube will have this lecture. So we're going to put it there and you can always visit it, and there is no charge for it, okay? Now we're going to look at what is called pathologic exfoliation. And I suspect that one day very soon, you will go into an exam and somebody will tell you to define pathologic exfoliation, to explain how it occurs, and to explain the possible causes of pathologic exfoliation, and so on and so forth. So if you didn't come to this lecture today, you won't be able to answer that question. And this is a gentleman that I did implants for many years ago. This is a maxillary implant. In fact, I was very, very shabby in the way I took the history for this gentleman. I remember his name as Mr. Luis, and I remember that much later he told me he was migrating to Canada after I placed the implant. And one thing I noticed is that he lost a lot of the upper anterior teeth. And, you know, all the remaining teeth in the maxilla were very clean, white, no decay, and all the mandibular teeth, the same thing, white, nice, clean, no decay. And I never asked him how he lost the upper anterior. That was a big problem for me in this case. So, I mean, I had placed the implant very early in December, and I flew in Jamaica, and I flew to Trinidad for Christmas. And I think on Boxing Day, he called me saying that one of his implants is coming out. And I said, no, Mr. Luis, it's not possible for your implant to be coming out. And I will soon be back in Jamaica. And when I came to Jamaica, this is what I saw. Implants that I had actually buried in the bone and covered with gum, was now coming out. That is called exfoliating. Um, After about 2 weeks, I was a little bit worried why this was happening. And what I did was I used the needle holder, the fine needle holder, to hold on to the coronal part of the implant. I screwed out the cover screw because I didn't really know what to do at that time, but I was exploring. And this is the situation. And I took out the cover screw, and then I raised the flap, and I saw that a lot of the implant that I was actually in the bone had now been exposed, and you can see it there. That is the exposure of the implant. And basically, um, I decided to explore further, only for me to see that there is a retained root in the area where I had placed implant. The periapical X-ray that I took for this case and the Panorex X-ray did not really depict the retained root and I'll show you why. That's the retained root, huh? Big and nice. And so what I did was I harvested bone from the mandible, a lot of bone, and you can see where I removed the retained root. That is right there. And it is the infection in the retained root from the retained root area that caused the exfoliation of this implant. So I cleaned out everything and I grafted with bone, and I even had a lot excess bone. And this is why it is important for you to measure the exact amount of bone that you need so that you don't harvest too much bone. Another thing that can cause pathologic exfoliation, I will tell you after you observe this suturing. So that's watertight suturing. So now, when you drill to place a 12 mm implant, and you didn't drill completely to 12 mm, and you only drill 11 mm or 10 mm, and you're trying to force the implant further apically with the driver, you are putting undue pressure into the osteotomy site. And after you close up, the pressure will want to let out itself, and you're going to end up with exfoliation of the implant. And this is pathologic exfoliation. So I want you to understand that foreign body and infection from foreign body and undue and unnecessary pressure into the osteotomy site with the implant driver are the most common cause of pathologic exfoliation. I'm going to quickly introduce you to peri-implantitis by defining peri-implantitis to you and telling you how it is diagnosed and treated. But I'm going to be a little bit stoush. I'm going to say to you that peri-implantitis should actually not be called peri-implantitis. It should be called peri-implantoclasia. And the reason is implants are not tissues. Implants are metal. So despite the fact that peri-implantitis has similar clinical features with periodontitis, it is not worthy to call this disease peri-implantitis because implants are not bone, are not tissues. Implants are not living tissues, and they are metals. And peri-implantitis is to be called peri-implantoclasia. But over the years, a lot of literature has been documented as peri-implantitis, and as such, we continue to call it peri-implantitis. So when you come to the exam and you see peri-implantoclasia, it is for you to identify that peri-implantoclasia is the same thing as peri-implantitis. So the definition of peri-implantoclasia or peri-implantitis is chronic inflammatory process with bone loss and pocket formation around an osseointegrated implant. Now, this definition says osseointegrated implant, but it can happen with osseointegrating implant. Okay? So failing implants due to periimplantitis can be successfully treated by surgical procedures that use either bone fillers or membrane combined with antimicrobial chemotherapy. This is a fantastic slide. This is saying that you can do bone filling, you can use membrane, and you can give antimicrobial chemotherapy. In one slide, telling you three different modalities. Now, what do you see with periimplantitis? The clinical signs that you see of a failing implant are similar to those that you find in periodontally diseased teeth, and these include suppuration, bleeding. Very rarely will there be pain because implants do not have nerves, and then increased bone probing, there will be mobility, and there will be radiographic evidence of bone loss. And you must investigate. You must take a history. The patient may not be from your office, maybe from somebody else's office. Take a history from the patient, and maybe take a history from the dentist who placed the implant, even if he's not your friend. And then you do further clinical investigation at chairside. You do radiographic examination, which can be dental panoramic tomogram, periapical X-ray, and bite-wing radiogram. And you should do culture and sensitivity. So after your culture and sensitivity, you can start with empirical antimicrobial treatment. And then when the result of the culture and sensitivity comes, you begin to give the appropriate or the so-called specific antimicrobial chemotherapy. And then subgingival curettage can be done versus flap surgery with guided tissue regeneration. Be smart, throw away subgingival curettage, go for flap surgery with bone grafting and guided tissue regeneration. These are pictures relating to failing implants, and you must go through them and read the captions that are there. And these are also failing implants, clinical picture of the explored sites. So just to give you a little break, I mean, you wonder, why are we placing these implants? We're placing these implants because we're going to restore them, of course. And sometimes you need to look at how you're going to restore these implants. And one very expensive way of restoring these implants was the manufacture of Atlantis abutments. I think this has faded away because it was very expensive, and a large fee for an Atlantis abutment and the crown was close to 1,000 US dollar. So what will the dentist charge? And they say it is simple, it is highly aesthetic, yes, and it is very profitable. Well, I don't know about the profitability. I lost millions of dollars when I was using the Atlantis abutment. But I use the Atlantis abutment to promote my implantology practice by shouting here and there, I'm using Atlantis abutment, I'm using Atlantis abutment. And all my restoration was Atlantis abutment, and I lost a lot of money. I didn't gain. Okay? So using the advanced manufacturing process, Atlantis is able to manufacture two functionally identical abutments, the Atlantis abutment and the duplicate. So made from commercially pure titanium and have the same shape and dimension and industry leading tolerance. So no other product in the implant industry at that time gave the clinician the power to provide a high level of aesthetics for their patient while simultaneously reducing cost and complexity for themselves. You see, the reduction of cost I don't know. It did not reduce cost for me. It increased my cost. But the restorations were fantastic. They fitted nicely. The aesthetics was very good. So in terms of not having to repeat the work, they were profitable. So Atlantis will provide you with two identical abutments. You place the first abutment, the primary, on the implant in the patient's mouth along with a provisional crown. And once the soft tissue has healed, you have you have determined the final margin height. Then your laboratory makes the final abutment right on top of the second abutment, which is the duplicate. At the, at the final restorative visit, you remove the provisional crown and you cement the final abutment. So it is digitally machined right from the cast. Atlantis patented process combines in-depth dental research with high-tech imaging, three-dimensional virtual design, and precision machining to create anatomically correct and individually designed abutments. So the advantage is that it compensates for offset or angled fixture. So that is one advantage. In other words, when you have a wrongly angled implant, the Atlantis abutment can compensate. And it has a natural, aesthetically correct shape, and then maximize the crown retention. And sometimes you may actually think that you don't need cement because the way it fits in snugly. And then it provides the ideal corona preparation and create parallelism in complex multi-unit cases, and it is compatible with virtually all implant systems. So this is the Atlantis abutment, very nice. And this is the final work going in. And now I want to talk to you very quickly on why do dental implants fail. And I'm a very simple lecturer. I don't like to use my lectures to scare patient students. I try to make it simple, but I'm going to tell you that I suspect that if an implantology question is going to come in your exam, you must be able to tell us why do implants fail. And I must tell you at this stage that I have been invited to set some questions. So the definition of dental implant failure. This is the total failure of the implant to fulfill the functional purpose, the aesthetic purpose, and the phonetic purpose because of mechanical and or biological reasons. And this definition is fantastic. And as a lawyer, if there is a case in which a patient purports that, oh, my implant has failed, then I can use these definitions to win the case as a lawyer of the claimant. And I can also use it to win the case as a lawyer of the defendant. Think about it. Now, dental implants may fail for different reasons, and one must differentiate between failure of implant and complication. And I've told you about failure of implant earlier on in this lecture. The fracture of the connecting screw or the prosthetic part may be considered as complication and not failure. And then the warning sign for implant failure include connecting screw loosening, connecting screw fracture, gingival bleeding and enlargement, purulent exudate from enlarged pocket, and so on and so forth. The warning sign of implant failure is that pain is not very common. So usually Because there is no pain, the implant will have failed considerably to the point that it is now very mobile, and it is only halitosis due to the pocket formation and its content that will bring the patient to you. Fracture of prosthetic components can be a warning sign. Angular bone loss noted on the X-ray is also a sign. And long-standing infection and soft tissue sloughing during the healing period of the first phase of the implant is also a warning sign. And this tells you that implant can begin to fail before it is restored. So classification of dental implant failure, you can divide it into, I would say, forget about number 7. You can divide it into the etiology, the timing of the failure, the condition of failure, the responsible personnel, the tissue involved, and the failure mode. With regards to the etiology, this includes failure due to the host factor, and like is the patient a diabetic patient, or due to surgical placement, so that is the dentist's fault, or due to implant selection, that is the dentist's fault, or restorative problem, that may be the dentist's fault or the laboratory fault, and so on and so forth. So let us look at host factor. One is osteoporosis and other bone disease. And in my younger days, when I had a diabetic patient, or I had a patient who is above 60 years old, especially female, I'm going to do bone density scan and so on and so forth. I'm always very careful, and really, it never really went against me or went in my favor. My success rate was always over 97% in my surgical placement of implants ever since. And uncontrolled diabetes is also a host factor as it causes delayed healing and repeated infection. Smoking habits can lead to failure of implant, and long-term smoking predispose the patient to poor bone quality, which directly affects the lifespan of the dental implant. It also seems likely that reduced vascularity of bone is the predominant mechanism for failure in smokers. So parafunctional habits include bruxism and clenching, and oral status, poor home care, juvenile and rapidly progressive periodontitis, and irradiation therapy. Now, surgical placement, off-axis placement, like severe angulation, lack of initial stabilization of oversized osteotomy site. So don't make the osteotomy site too big. And if you make it too tight, you might end up having pathologic exfoliation. You must make it precise, all right? I mean, we can think about this in our day-to-day running as male and female with the opposite sex. Impaired healing and infection because of improper flap design can lead to failure, and overheating of the bone and exerting too much pressure can also lead to implant failure. Minimal space between implants, placement of implants in the immature bone grafted site can also lead to failure. And then placement of implants in an infected tooth socket or pathologic lesion can also lead to failure. And implant selection, improper implant type or improper type of bone can lead to failure. And if the implant is too short, it can lead to failure. And then too wide implant can lead to failure. And then you need to consider the number of the implant, the width of the implant, and the proper design for the implant you have chosen. And this is a checklist. And if you have this checklist on your case note, Ms. Haven, I want you to have this checklist on all the case notes of implant patients. When you have this checklist on the case notes of all your implant patients and they sign to it, what it means is you have told them that the implant can fail, and they understand and agree that the implant can fail. All right? So it's very protective. And these are illustrations, radiographs of failing implants. So in conclusion, implant failure is multifactorial and occurs at different stages of the procedure. A checklist relating to dental implant surgery and its related causative factor is provided to aid the clinician in assessing, tracing, and improving clinical results. So what we're going to do very quickly and lastly, I believe, is the dental implant therapy in the management of oral-oral communication. And this is my thing. It's a new technique for simultaneous closure of oral-oral communication and maxillary sinus grafting and subsequent immediate placement or delayed placement of implant. So the advantage of this closure of the oral communication is that both hard tissue and soft tissue closure is achieved and is excellent. And it is easy and it allows subsequent placement of dental implant and no donor site is required to take bone or harvest bone. The publications that I've done on this have had very high impact factor, and this technique has been widely utilized by clinicians worldwide. To my knowledge, there is no disadvantage, not because I'm the one that created this technique. However, the limitation includes cost and technique sensitivity. And in comparison with alternative methods of oral closure, the buccal sliding flap, the palatal flap, the soft palate flap, and often related modalities have been used previously for management of oral communication. All these techniques have a common shortfall. The buccal sliding flap reduces the depth of the vestibular sulcus, hence you will need vestibuloplasty after. And then only soft tissue closure is achieved, hence the need for complex bone grafting in the maxillary region when endoosseous implant is considered. And then severe pain and scarring in the palatal flap and prolonged healing period for palatal flap is also a disadvantage of other procedures. So with regards to this procedure, which I eventually called the sandwich bone regeneration technique, some cancellous granules of bone substitute is sandwiched between two sheets of approximately trimmed bioguide, and you can use any membrane. You don't have to use bioguide. The bioguide must have been approximately appropriately sutured on three sides with resorbable suture. You have to use resorbable suture because you are implanting it there and you are not going back for it to take it out. So after the bone substitute has been placed in the now pillowcase, then you now suture the fourth side also with resorbable suture. And then the sandwich, which is prepared in such a manner that it has a smooth side and it also has a rough side, is ready to be utilized. And this is the formation of the sandwich, two sheets, pillowcase, and then you're tucking the sandwich into the oral communication in such a way that the convexity of that sandwich that you're tucking in is towards the sinus and the concavity is towards the alveolar bone. So the convexity which is towards the sinus has a smooth surface, and the concavity which is towards the alveolar bone has a rough surface. And then you can fill additional bone into the concavity and marginal alveolectomy is performed, and then the flap is repositioned and sutured, and it has to be watertight sutured. And you can see this first case, or is it the second case of sandwich, yeah, that I did, second case. You can see the oral-antral communication right here. That's it there. And you can see what we did later. It's the amount of bone that we regenerated is amazing, really, really amazing. And we subsequently placed an implant there, and I'm not sure if how fantastic. You can see the illustration of the implant that we placed there. And you can see the same patient, you can see the dental site in the lower jaw. You can see that mesial filling of that premolar. I'm just going through to show you that it's the same case. And I'm not tricking you. That's what we did. Fantastic. So we're going to look at the role of quantitative single photon emission computerized tomography in the assessment of the osseo integration of the Ogunsalu sandwich regeneration technique. I'm not going to do so much on this other than in the electronic material that I'm going to give to Professor Bayo Fashola, and my publications in this area will be included so that you can appreciate how the osteoblastic activity of the sandwich technique and also of any bone grafting technique that you utilize can be assessed. So this technique is simple, excellent bone grafting in the maxillary sinus, which allows subsequent placement of endoosseous implant. No donor site surgery is needed, and we push for it to be called the Ogunsalu sandwich bone regeneration technique, and that is what it is. So this is the West Africa College of Surgeons revision course for part 1 and part 2 examination. And like I said to you, to assist you, I am going to place this on the virtual dental TV, which is on YouTube, so you can go for it. Thank you, ladies and gentlemen.